Good morning. My name is Ionela Iacobas, and I am a pediatric hematologist-oncologist at Texas Children's Hospital Vascular Anomalies Center in Houston, Texas. We will discuss about immune dysregulation in lymphatic anomalies. As my disclosures, I have received the Lymphatic Malformation Institute grant in 2015, and part of the data from this presentation were the results of the study from this grant. As an outline today, we will quickly summarize the lymphatic vasculature role, and then we'll review the immune dysregulation due specifically to the condition, to the lymphatic anomaly, and then the immune dysregulation due to the treatment of the lymphatic anomaly. I definitely have no intention of giving you a 3-hour lectures on lymphatic circulation and lymphatic roles, but just important to remember that the lymphatic vessels in themselves, they are not just passive roadways in the body. They have multiple functions regarding depending on the area of the body that they drain, the area of the body that they serve. So they absorb the fat from the intestines. I think this would be the most commonly known function. But outside of that, they transport the fluid from the tissues to the main circulation, so back into the blood, back into the mainstream. They transport large molecules from the tissues back to the blood, again, proteins, antibodies, fat, etc. And then they also function as an important step in the antigen presentation in cooperation with the dendritic cells. So outside of the lymphatic vessels in themselves, we have somewhere close to 800 lymph nodes in our body. Depending on the paper you read, some say about 600, some 800, but basically along the way of the lymphatic vessels, there are the lymph nodes, which function as filters of water and cells. So the lymph nodes will remove or filtrate some of the water that is absorbed in the lymphatic vasculature, and will also remove, again, filter some of the cancer cells. So if you remember, this is one of the reasons why the lymph nodes that are the closest to an area of a malignancy will be invaded first. But from our purpose of today's discussion, the lymph nodes are extremely important because they function as a maturation, as a training camp, if you want, for lymphocytes. It's like a high school for lymphocytes, where they get presented with pieces of bacteria or viruses, so they get antigen presentation, and they will both learn how to resolve the current infection, and also will try to memorize, will try to remember the current injury, so that they will be able to have a fast response in the future. Now, in lymphatic anomalies in general, this perfectly built, if you want, tree of the lymphatic vessels has some areas that are not following the blueprint, that are not following the initial plan. So some areas of the body are not drained properly. So the lymphatic fluid is not returned to the main circulation and doesn't reach the lymph nodes, doesn't reach the training camps as they are supposed to. So in these cases, there are some inherent complications that will be encountered. So in simple lymphatic malformations, there will be cellulitis or infection within the malformation, and obviously bleeding or functional impairment. While in complex lymphatic anomalies, we encounter bone lytic lesions, effusions, so fluid accumulation in pleural, pericardial, peritoneal space, And this effusion will predispose to infections either within an area of a lymphatic malformation or within the area of the effusion, or just as a simple, again, overall systemic infection. And then in KLA or Kaposiform lymphangiomatosis, we see significant complication from bleeding. In all of the complicated lymphatic anomalies, we may have thrombosis events. And then, as mentioned before, it can be functional impairment, mass effect, discomfort, and malnutrition. Unfortunately, the cause of death in complex lymphatic anomalies is usually related to one of the three entities. So a lot of times it is due to sepsis, and then respiratory failure or bleeding. So in a lymphatic anomaly, the lymph loss or the lymphatic fluid not returned to the main circulation is lost either externally due to leaks from lymphatic vesicles or to drainage of an effusion, or it can be trapped internally within macrocysts, within the effusions, or within lymphedema. And in the picture I showed you over here, it's a child that has a simple lymphatic malformation on the neck, so in the cervical area and the anterior mediastinum. But again, you can see that even in simple lymphatic malformations, this fluid gets trapped within the cysts, and again, it is not returned to the main circulation. So those lymphocytes that are trapped within those cysts, again, they don't get they don't go through the typical maturation process. In lymphatic effusions, even more. So in complex lymphatic anomalies, there is a higher loss of the lymphocytes. So normally in blood, there will be somewhere between 15 to 60% of lymphocytes, where the effusions will have above 80% of lymphocytes. So in the case I was showing you over here, on the same day, the patient had about 16% of lymphocyte content in the blood, and the pleural fluid had 78 to 90% of lymphocytes content. This is the data from the study I mentioned before, where we looked at different types of lymphatic anomalies, from simple lymphatic malformation to generalized lymphatic anomaly, Gorham-Stout, and again, complex lymphatic anomalies in general. And we try to see in how many cases we notice lymphopenia, so less than normal lymphocytes in blood. When we reviewed 309 cases of lymphatic malformations, 27% of the patients had low lymphocyte count, 55% had normal lymphocyte count, and for about 18% of them, it was never checked or data was unavailable. So if you want to look at these numbers in a different way, out of the 253 patients with lymphatic malformations that had an absolute lymphocyte count checked, about 33% had a low lymphocyte count. And regarding hypogammaglobulinemia, again, from the same number of patients, only about 5% of them had low IgG and 8% of them had normal IgG, but very, very large number of patients had never an immunoglobulin level checked. So we don't know, again, if this will remain statistically significant or not, as again, the 87% of the patients did not have an IgG level ever checked. We did find statistical correlation between lymphopenia and effusions, between lymphopenia and lymphedema, and again, it makes sense because in effusions you have a large volume of lymphatic fluid that it's not drained within the main circulation, and lymphedema the same. So lymphedema can trap very large amount of lymphatic fluid in the tissue. We did not find any statistical correlation between lymphopenia and the need for IV antibiotics or hypogammaglobulinemia and the need for IV antibiotics. So again, this doesn't mean that the lymphopenia it's not a cause of infection, but again, it's not a cause of bacterial infection. In 2019, we have published the multidisciplinary guidelines for the initial evaluation of complicated lymphatic anomalies that came as an expert opinion consensus from the Second International Conference on Generalized Lymphatic Anomaly and Gorham-Stout disease. And we have asked or recommended the medical teams to include the lymphocyte count and IgG level in their evaluation of patients with complicated lymphatic anomalies. We want to thank the lymphatic anomalies registries for allowing us to use their data. And now very quickly, the sirolimus is the most commonly medical therapy for complex lymphatic anomalies, and it is an immunosuppressant. So please consider pneumocystis jirovecii prophylaxis when using sirolimus. If you have a fever of 101 or any other sign of infection, please request to be seen by a medical provider, so to have an evaluation. And even though in a small number of patients, but severe infections complications were reported in patients on sirolimus. And I couldn't help but add a slide on COVID just because it seemed quite timely. The patients on sirolimus for various indications, including liver transplant, did not have a higher mortality due to COVID infections. There was a recent publication, again, specifically on patients on liver transplant. So please do not stop the targeted treatment for the lymphatic anomaly without discussing with your medical team. As you know, patients on sirolimus should not receive the live vaccines, but at least the COVID-19 vaccines that are approved for use in the United States, they are all inactivated, so they're still allowed and recommended for patients while on sirolimus therapy. Thank you very much. Any questions?